Hello everyone, this is Arvind Rajamani. Australia has been hit by a COVID wave, and I thought it might be an opportune time to talk about how to intubate a patient with known COVID or highly suspected COVID. And for this, I'm going to rely on two documents. One by the Mayo Clinic, which is they have issued an adult and a pediatric intubation checklist, and the second one is my own hospital, where my colleague has put together a brilliant practical plan. Okay, now the first the what are the principles of airborne precaution intubation? So COVID, the intubation itself is not any different. So the most important thing that I want to convey here is that the actual act of intubation is not different. The actual airway management itself, finally, it'll follow the following steps. So just like with every single intubation that you do, there is an initial planning phase, and then you have to pre-oxygenate, and I gently pre-oxygenate even while I'm planning. Induction of anesthesia, a laryngoscopy, followed by intubation, and then you do your post-intubation checks. So there is absolutely no difference in the sequence of events. So what is the big deal? Why are we bothering about this as if this is a completely different beast? The main thing is the safety of us, our safety. That's the biggest difference, because here you don't want to be affected. You don't want either yourself or your staff to be affected. And therefore, you do subtle changes and sometimes major changes in each of these steps. Okay, so let me go to the Mayo Clinic guidelines and go and see what steps, what might be the differences. Okay, firstly, I'm going to talk about the similarities. I'll be talking both about the similarities as well as the differences, so that at the end of it, you'll hopefully understand that the actual process of intubation, the actual process of induction of anesthesia, etc., you don't actually need to change anything significantly. Okay, so you develop a plan. Okay, if you think you're going to have a difficult airway, then obviously the most senior person. Okay, you pre-oxygenate, and in pre-oxygenation, what are the differences? You try and encourage spontaneous breathing rather than and try and not do things like awake intubation, non-paralyzed intubation, etc., because of the risk of failure and also the risk of aerosolization. Okay, next, the laryngoscopy itself is preferably a video laryngoscope right at the first time. Just like with every other intubation, the first attempt is the best attempt. Okay, therefore you try and do as much. During the first attempt, my practice will be to actually do this. Direct laryngoscopy. Video laryngoscopy with a bougie. Okay, that's what I do. In the Mayo Clinic checklist, they say video laryngoscopy, and then if it fails, then you can try other things. Okay, if it works, great, no problems. There's no difference at all. However, if it doesn't work, so this is your plan A. Okay, now you come down from here, you have plan B. What is plan B? The typical checklist that you might have, the typical things that you might do will be, you have to change something. So reposition the patient, then try to find out what the problem was during the first time, and therefore, it might be a problem with laryngoscopy, a problem with intubation, etc. So reposition, attempt it with perhaps a different laryngoscope maybe, and then and this time definitely use a bougie. If this fails, okay, in a non-COVID intubation, what we would often do is to do mask ventilation. Okay, however, in a COVID in an aerosol or airborne in an airborne precaution intubation, we try and avoid this, and rather than this, you can put in the supraglottic airway, such as an LMA, and the reason for that is that this will avoid the aerosolization. However, okay, If you absolutely need to mask ventilate, I would mask ventilate, but with two hands, tight seal, and somebody else ventilating the Lidl bag for me, the ambu bag for me. Okay. Now, if this also is a problem, then you will now go to a surgical airway. Okay. Or you could do fiber optic intubation through an SGA, etc. But by the time you come here, you should be prepared for a scalpel bougie technique. Okay, for a surgical airway. Okay, this is the overall checklist. So you can see here that the differences are mainly with regards to trying to avoid mask ventilation. Okay, an earlier use of an LMA. Okay, and perhaps a slightly earlier decision making for a surgical airway. But personally, I would prefer now to do a mask ventilation and rather than a surgical airway, because if you think about it, if we are in full PPE, okay, if we are donning full PPE, okay, then even if there is aerosolization, we are likely to be protected. That's number one. Number two, we are assuming here that a front of neck access or a surgical airway is actually going to be easier, or at least less risk of aerosol generation than bag and mask ventilation. However, if I can ask you, how many number of times have you done mask ventilation and how many times have you done a surgical airway? Okay, I therefore would advocate for tight two-hand bag and mask ventilation to get the oxygen sats up, because the vast majority of patients do not have a difficult laryngoscopy, and therefore the vast majority of patients we should be able to get an airway from above. Okay, having said that, this is a senior person's call, and the biggest difference, as I said before, with this with the COVID intubation or an airborne precaution intubation and any other routine intubation is the time point here is often you could potentially reach this earlier. Okay, so you have to have this plan worked out well before. So this development, so develop a plan, okay, and then you then talk about affirm the roles and backup intubation. So all this is part of the preparation. Okay, now the other things, as far as the intubation is concerned, do not do awake intubation or non-paralyzed intubation, because that will minimize your chances of first pass intubation. So your success rate will be significantly lower. Therefore, always do RSI. The second, with regards to rapid sequence intubation, we have decided in our unit that we will use suxamethonium rather than rocuronium unless there are contraindications to suxamethonium. And the reason for this is because suxamethonium has a defined visual endpoint of fasciculations, whereas with rocuronium, it is a time bound thing. It is, you look at the time and you don't really know whether the rocuronium has worked. Okay, then a senior clinician should intubate, try and do video laryngoscopy, and then other things will be large ETT, etc. Okay, now this thing here, you need to communicate with people. The team, half of the team will be outside the room, so you need to have a good communication. So the differences, therefore, once again, from a routine intubation, let me just circle just the differences so that you will finally know that there are very, very few differences between a well-planned intubation in an aerosol in COVID versus non-COVID. Okay, try to avoid non-paralyzed and awake intubation. Use a video laryngoscopy. Okay, earlier use of a supraglottic airway such as an LMA. Okay, rapid sequence intubation, this is something we've covered before, I think. And then communication to the outside. That's all. If you think about it, the actual process, no difference. All this is about planning. Okay, right. Then in the Mayo Clinic published document, you have all of these are the planning, the preparation of the supplies. Okay, so you'll have to have a checklist to talk about the ventilator, the viral filters, etc., etc., etc. Okay, and see here, waveform capnography is preferable, and the reason for that is because they say it's because calorimetry means you need to disconnect the circuit. You don't want to do that. That's number one. And also for me, I try to use waveform capnography whenever I have even 5 minutes of preparatory time, which is virtually all the time. And the reason for that is that it's the best way of checking whether the endotracheal tube is in the airway or not. Okay. Then to prepare, these things, little things, extra blankets or towels for ramping up to get the patient into position, especially if the first attempt of intubation fails. Okay, then you can try point of care ultrasound. It's not something that I would advocate personally. And then all of these things, viral filter, try and use an HME, the supraglottic airway device, the syringe to inflate all of these things are exactly the same. There's virtually no difference whatsoever. Okay, so this part, once again, what you will find is that there's virtually no difference between a routine intubation and this. This also, there's no difference, and I said already that succinylcholine is our preferred agent, and that's purely because it's a little bit quicker, but also B, you have a defined endpoint. Okay. Now, with the staff, most important thing, PPE. Okay. Now, this is the second important difference. This is the other important difference between a normal intubation, a non-COVID intubation. So, coming back to our safety. Okay. This is one of the few times where you will put yourself and the safety of yourself and the safety of your staff above that of the emergent needs of the patient. Okay, I would, if the patient, even if the patient is in respiratory distress, I would not enter the room without following all the PPE guidelines according to your local protocol. Okay, the second. Okay, so that's very, very important. Do not go in without having PPE, full PPE. Okay, airborne precaution PPE. Then limit the number of personnel. This is nobody. There's no, and we'll talk about what we have, what my colleague has developed for my hospital, and then all of these things: double glove, hand sanitizer every single time, PAPR, etc. Make sure that the height is perfectly good. Remove, then make sure that this head to sternal notch, ear to external auditory meatus to sternal notch, so ramp it up. This is the sniffing position, etc. All of these things, which I would follow in every single intubation, whether it's COVID or non-COVID. Okay, so the main difference between COVID and COVID intubation in this is the fact that you do PPE, you limit the number of people, you double glove. Okay, and you have hand sanitizer. So it's all about protecting ourselves rather than the actual process of intubation. Okay, then oxygenation, because of the high desaturation risk, you pre-oxygenate and take deep breaths. But see, the deep breaths, they say, are discouraged, and the reason for this is because deep breaths can sometimes provoke a cough, and that can obviously promote aerosolization. Okay, then 2-hand seal and tight fitting bag and mask ventilation, right? If they're already on high flow, do not discontinue. Okay, continue the high flow, continue the NIV, and these are things that I do in every other intubation. So I don't think there is any difference at all between this and a non-COVID. The only thing is that try not to increase the high flow more than 50 liters because of the risk of aerosolization. Okay, now it says try and avoid this bag valve mask ventilation, but remember, for me, I would try and do a 2-hand technique to get back to get back a patient who is desaturating rather than him or her going into a hypoxic cardiac arrest, and then it becomes an uncontrolled situation, purely because a front of neck access for me is something that is extremely rare, and there is a very high risk that it could go out of control and result in aerosolization. But that's just my bias. Okay, right. Then once you have, this is all the preparation, you stop, review the plan with everybody, and then you go into the room to secure the airway. And once you have secured the airway, okay, now before the positive pressure breath, you inflate the cuff, attach the capnograph, the EtCO2 waveform, capnograph waveform. Okay, that's okay. Secure the ETT and then remove the outer gloves and apply hand sanitizer, and that's purely because by now it's obviously nicely contaminated. And after that, just look after the patient, start all that, lung protective ventilation, etc. So no major differences. And this disinfection once again. So if you think about it, apart from the infection control and safety from an infection control viewpoint, there's very little difference. And the differences in the process are once again related to the minimization of aerosolization rather than the actual process. Okay. Otherwise, you will do the same plan A, plan B, plan C that you would normally do. Okay. But you take extra care to talk this out with everybody. Now, let's talk about the logistics, about the actual the number of personnel and who does what, etc. That's a very important thing. Once again, this is the planning stage and the preparation stage. Okay. Now, if you close your eyes and think about the scenario, this is your ICU bed, and you have the patient here who is ready to be intubated. Okay. Now, most likely you will have a nurse, an ICU nurse, who will be standing here by the bedside, trying to organize the ventilator, trying to make sure that the IV access is good, setting up the high flow nasal adjusting the high flow, all of these things. This red line here is the outside the room, and we do not enter that till the rest of the team does not enter that. Okay, we are going to keep a lean team. And how many people will we need? Firstly, let's look at the tasks that are required. You need one team leader. You need 2 people for the airway. So you need someone to intubate, and I'm going to call this an assistant. It could be a nurse or a doctor, an airway assistant. Okay, I'm going to put the breathing here. Sorry, not there. Just after, I'm going to put the breathing here. Circulation, you need IV access and drugs. And then you need somebody to set up the ventilator and connect the ventilator. So that's the breathing part. And the runner is the person who will go and get you extra supplies, etc. Okay. If you think about it, all of these things can be done by 3 people inside the room and 1 person outside the room to help. How can we do that? The team leader will be a senior doctor, and the team leader, after doing all the planning and preparation outside the room, they will the entire team will don the PP and they will go into the room. And once they're inside the room, the team leader is free enough to be the circulation doctor or circulation person. Okay, either doctor or nurse. Okay, so the team leader and the circulation person will be exactly the same. So this is one single person. So IV access and drugs. Okay, then the 1 minute. Let me put this in a different color. Okay, the airway requires 2 people, a doctor and an assistant for the doctor. Okay, so obviously this will be non-negotiable. The assistant should preferably be the bedside nurse who's already there. Okay, and that bedside nurse can already set the ventilator settings and all that. And at the end of the intubation, the bedside nurse's job will be to attach the ventilator, inflate the cuff, and attach the ventilator and the capnogram. Okay, and that means that you can do the whole thing with just 3 people inside the room, one team leader who can either be a senior doctor or a senior nurse, it can be anyone, okay, an airway doctor and an airway assistant, these three people. And the team leader's job will be to look after the circulation for a bit, and the airway assistant's job will be, after the airway is secured, to then inflate, to look after the post securing steps of cuff inflation, checking the tube, attaching the ventilator, etc. Okay, the outside person will be, there will be a two-way communication between the inside of the room and the outside of the room, and the person outside will be responsible for getting any supplies that are required if things go wrong. For example, if they need a front of neck access, etc. Okay. Now let's look at the document that my colleague has put together regarding what each person does. Okay. Now the bedside nurse, okay, who is inside the room, and this is okay, their role will be before the intubation to pre-oxygenate, nasal cannula, suction, all of these, setting up everything up. During the intubation, they are going to be the airway assistant. Okay, well, I think here we are assuming that it could be a second person to assist the airway. Switch the ventilator from high flow to, okay, so once the intubation is done, then once the intubator is ready to hold the face masks, then you manipulate the machine, the ventilator, setting the ventilator, etc., etc. And post intubation, what you do is you attach the ventilator, EtCO2, and after that sedation and so on. That's the role of the bedside nurse. What is the role of the team leader? Before the intubation, they're outside the room, and their job will be to allocate the roles clearly to everybody, to choose the induction drugs and the doses, to make sure that there is a nice plan A to D articulated, as we saw in the Mayo Clinic document. Okay, the communications, make sure that it's working. Okay, and finally do a checklist. During the intubation, they're inside the room, and they're going to confirm that the IV access is working. Okay, and then if there is no bedside nurse, this person can be responsible for switching on and connecting to the ventilator. Okay, and during the intubation, their job will be to actually do the induction, communicate with outside, and if required, then look at the second pair of eyes, because this is the senior person attaching the ventilator and so on. Okay, the actual incubator, it must be the most senior operator, plus the airway assistant. Okay, before the intubation, plans A, B, C, D, choose, confirm that they're working. So this is all exactly the same as any other intubation. In other intubations, in the non-COVID intubation, we don't particularly pay much attention to whether or not, because we know that if something fails, you have a bigger margin of error. Here, you want to go in, you want to achieve, because you're not going to bag and mask and ventilate to rescue somebody's oxygenation. Here the stakes are a little bit different, that's all. Okay, it means that you can go into a hypoxic cardiac arrest very quickly. And then the rest of the thing, all of these are exactly the same. Okay, during a peri-intubation, the job of the airway operator will be, same thing that they do normally. Okay, normal. This is all normal, so there's no difference at all. So two-handed. Okay, there's just one thing. Do a two-handed removal of a bougie, and what you do is when you're taking the bougie out, make sure that it doesn't flick in the air and release droplets that can aerosolize. Okay, you remove it gradually, keeping a gauze, okay, a piece of gauze, so that you're absorbing all the secretions. And then when you are keeping it back, just try to keep it in a place that's adjacent or even on the bed or anything. And same thing, be cautious with the blade placement. Just make sure that you keep it aside so that nobody comes in contact with it unnecessarily. Okay, and after that, all of these are cleaning it, etc., etc. Okay, now what's the role of the outside person? The outside person is mainly for the communication and getting equipment if required. Pre-intubation, you're going to check if it's confirm whether it's working or not. Then read out the airway checklist. Okay, that's the important thing about because the people inside the room are, they're active, their mind is on other things. And then during the intubation, if it's rocuronium, then timer for paralysis. If it's succinylmethonium, the airway, the team leader will look for fasciculations. Okay, and then just make sure that you compliment the team leader who's inside the room for the observations. And then anyone who's there for help will be these things. Okay, these are the things that they have to do. So you'll need, according to this, you'll need between 3 to 5 people totally, of whom 3 are inside, 3 to 4 are inside, and 1 to 2 are outside. Okay, outside the room. Now this is our intubation algorithm, and it's again beautifully written. If you look at it, there's not much difference between this and a non-COVID. This is just standard. Okay, for example, if you look at it, okay, everyone you're going to first pre-oxygenate. So let me just highlight. I'll underline the important steps and and what I will do is I will circle the differences, and you'll find that there are virtually no differences between this and a non-COVID and a non-COVID intubation. Okay, everybody is going to get 100% oxygen. The maximum flow will be 50 liters or so, and a maximum or 15 liters on a non-rebreather, and attach a viral filter. Okay, so that's one difference. So these two are different. Okay, again, for prevention of aerosolization, standard nasal cannula if you're going to do apneic oxygenation, so there's no difference at all. Check the suction, BP cycling, clear the table for airway equipment, check IVC, turning on communication, because there are 2 teams, one inside, one outside. So if you look at it, just this and this are the differences. Then outside the room, the team leader, incubator, etc., all of these are exactly the same. Role allocation, confirm communications is the difference. Then this is the same. This should be the same. You should be always doing plan A to D always. Okay, checking the airway equipment, fluid and pump set, instruct runners for intubation. So exactly, there's no difference whatsoever. Okay, and donning PPE is the only big difference. Pre-intubation, same as non-COVID. Okay, this is slightly different. Okay, compared to non-COVID. And then ensure capnography is attached. I actually use this even in my non-COVID intubations. Okay, bluey on the chest. Bluey is the absorbent thing, and that's to make sure that the bougie is taken out and it's kept on this thing. That's all. And then this is read the intubation checklist, but that should also be standard practice even otherwise. Okay, intubation. Avoiding bag and mask ventilation if possible. That's, for me, that's an important thing. So that's a slight difference. Okay, then 2 sets of eyes, one by the team leader, one by the airway person. Okay, by the incubator, and the second is by the team leader. Then bougie to be wiped with gauze and then placed on the chest on the absorbent thing, and discard once the intubation is confirmed. Okay, make sure that you keep it till you don't throw it until you have confirmed that the tube is in. Okay, otherwise you might need it for cannot intubate, cannot oxygenate situation, for surgical airway, etc. Okay, then straight onto the ventilator and confirm with capnography. So no major differences at all. There are just so few differences. Okay, apart from that, what are the things to go in? You'll want to take a Goodell's airway, either a CMAC or some kind of video laryngoscope or bougie. So virtually the same thing. Okay, and then all of these other things here are exactly the same as you would normally do. Okay, inside all of these are exactly the same. There's no major difference. The only difference could be that you might use a viral filter. Okay, heat moisture exchanger with a viral filter. Okay, so no difference. Okay, then team, this is a checklist, just like how the Mayo Clinic has a checklist. We are using a slightly different variation of the checklist, but same thing. So finally, my take home message out of this, number one, okay, don't panic. Okay, the process is the same. Process is exactly the same, except for aerosol precautions. Okay, the actual intubation is exactly okay. So don PPE, okay, and avoid things that aerosolize, such as bag valve mask ventilation or very high, more than 50 liters of high flow, etc. Okay, having said that, I would not have a problem in rescuing someone's oxygenation with a few breaths of double-handed mask ventilation. I would prefer to do that than risk ongoing desaturation, cardiac arrest, and a front of neck surgical access. I wouldn't want to do that. Okay, so but then that's just my bias. Okay, so all good. This could be in the CICM exams, a COVID intubation scenario could be a fantastic procedure viva. And what we'll be looking for will be about how well streamlined your thought process is. And if you just realize that, don't complicate things too much, keep the same process that you would normally follow, except for those steps that require aerosol, that are potentially aerosol generating. You can just breeze through, and you can, and even in your when you're intubating somebody, once again, just remember that you have good communication, explain the plans, and then don PPE and go in and execute those plans. Okay, if you have any questions, you can send comments. Thanks. Bye.